So the question is, what is paroxysmal supraventricular tachycardia and how do you treat it? The phrase supraventricular tachycardia actually refers to all tachycardias that are generated up or above the AV node. So that would include, amongst others, atrial fibrillation, atrial flutter, and AV nodal reentry tachycardia, AV-NRT, which often comes and goes and is the one that people often refer to as paroxysmal SVT. It is the commonest cause of palpitations in patients with normal hearts and occurs more often in women than men. Typically it goes at a rate of about 150 to 250 beats per minute and is narrow complex. It may occur spontaneously or be triggered by stimulants like caffeine, alcohol, or salbutamol puffers. So how does it work? Well, normally the electrical impulse starts at the SA node, spreads to the atria, then enters the AV node and goes into the ventricles via the conducting system. Most people have only got one pathway through the AV node, but in about 30% of people there are two pathways, a slow and a fast one. These people are the ones more prone to developing AV-NRT. In these patients, the impulse enters the AV node and goes down both slow and fast pathways. The fast side, being fast, conducts into the ventricles. The impulse then goes retrograde up the slow pathway and boom, collides with the slow impulse and stops. The only problem comes when there is a premature atrial beat that sneaks in just after this has occurred, because at this time the fast side is refractory, meaning the impulse can't go down it or up it. So the impulse that comes in from that premature atrial beat has only one choice, so it takes the slow pathway, like when the M4 is blocked and you're forced to go down Parramatta Road. By the time the impulse finally gets to the ventricle using the slow pathway, the fast pathway is out of its refractory state and the impulse can now head up the fast side. This can lead to a circuit where the impulse is going round and round, causing rapid, regular impulses into the ventricles and atria. And of course, it looks like this: narrow complex, normal axis, and sometimes you can see retrograde P waves. Generally, people tolerate the high heart rate reasonably well and turn up to ED with the sensation of palpitations and maybe lightheadedness. Essentially, to terminate the rhythm, you want to give a strong vagal stimulation. A modified Valsalva maneuver is probably the best option. Get the patient to take a big breath, then ask the patient to try and blow out the plunger from a 10 ml syringe for 15 to 20 seconds. Once they have done that, lie them down and elevate their legs. Success rates are about 20 to 40%. If that was unsuccessful, you should put in a large cannula and try IV medications. Firstly, adenosine. It works with a very fast half-life, but it's a bit of a nasty thing to do. Explain to the patient that you're going to flush in 6 milligrams of adenosine rapidly, followed by a normal saline flush. In 10 or so seconds, they will feel terrible, as if they're going to die, as the adenosine works on the AV node. The patient rapidly goes back into sinus rhythm. Just remember, it can cause bronchospasm, so don't give it to someone with a history of asthma. A kinder, but slightly slower option is to slowly give verapamil 1 milligram IV at a time over 5 to 10 minutes. I tend to draw up 10 milligrams, but reversion occurs usually by about 5 milligrams. If this doesn't work, take a big breath and speak to your cardiologist about what options you've got. For most patients that have reverted, they can be discharged after checking their electrolytes and warning them to avoid precipitants. Some patients will require commencement on antiarrhythmic medications. Done.